All right, today we're tackling a really high-stakes diagnostic challenge: how to spot a bowel injury after trauma. These things can be incredibly subtle, and if you miss one, the consequences are serious. So, let's break down the clues together.
Okay, picture this. You're in the ER, a trauma patient gets rolled in, you get a scan. The images pop up on your screen, but the actual injury? It's playing a mean game of hide and seek. Your job is to be the detective, to find that subtle piece of evidence that could literally save this person's life.
So here's our game plan. First, we'll talk about why these injuries are so sneaky. Then, we'll get into the two kinds of clues, direct versus indirect. We'll have a quick word on a critical tool, contrast, before we introduce a major imposter. And we'll wrap it all up with a showdown: injury versus its great mimic, shock ball.
So, what's the big deal? Why is this so hard? Well, when you have penetrating trauma, from something like a gunshot or a stabbing, it can cause these tiny but really significant holes in the bowel. The problem is, they don't exactly show up on a CT scan with a giant flashing neon sign. The evidence is often just frustratingly subtle. And this, right here, this is the core of the problem. This is the tightrope that every radiologist and trauma surgeon has to walk. Just because you don't see that smoking gun sign doesn't mean your patient is in the clear. And, on the flip side, just because you see some fishy-looking signs, it doesn't automatically mean you have to rush them to the OR. It's a real gray area.
To find our way through that gray area, we have to think like detectives and organize our evidence. And really, all the clues we find fall into two main buckets: direct signs, which are our smoking guns, and indirect signs, which are kind of like circumstantial evidence.
Think of it like this. On one side, you've got your direct signs. This is the slam dunk, definitive proof, the smoking gun that basically screams, yes, there is a hole in the bowel. But then on the other side, you've got the indirect signs. Now this is your circumstantial evidence. It makes you really suspicious, for sure, but it doesn't lead to a conviction all by itself.
So, what are these smoking guns we're talking about? There are really two big ones. First up, spilled oral contrast. If you give the patient a special drinkable dye and then you see it leaking outside the bowel on the scan, well, you've found your hole. Game over. The second one is an active mesenteric bleed. This means you can actually see blood actively pumping out of the vessels that feed the intestines. Both are unmistakable signs of a major injury. Now for the indirect signs, and honestly, this is where things get tricky. You might see something called fat stranding, which is basically inflammation showing up in the fat around the bowel. Or maybe you see some fluid hanging out where it shouldn't be. Both of these signs are telling you something is wrong, but they don't definitively prove there's a perforation.
So, we just talked about oral contrast, and it's a huge help for finding a direct sign of injury. But like any powerful tool, you have got to choose the right one for the job. Because if you choose the wrong one here, you can make a really bad situation so much worse.
Here is a super simple rule to live by anytime you think there might be a leak from the GI tract. Barium is always bad. Look, barium is a fantastic contrast agent when you know for sure it's going to stay inside the bowel. But if it leaks out into the abdomen, oh man, it causes a severe, life-threatening inflammatory reaction. It's called barium peritonitis, and it is a disaster.
So the correct choice, the only choice here, is a water-soluble contrast agent. If that stuff leaks, the body can just absorb it, no big deal. Barium, on the other hand, is going to sit in the abdomen and trigger a massive inflammatory attack. So the takeaway is simple. In trauma, it's water-soluble or it's nothing. Okay, so we've learned to look for direct signs and indirect signs. We know to use the right kind of contrast. We're feeling pretty good, right? But what if the body is sending you false signals? What if those indirect signs we're seeing, that thickened bowel wall, that fluid, what if it's not from a traumatic injury at all? And that brings us to the great mimic, the absolute ultimate confounder in this entire diagnostic puzzle: shock bowel. This is a condition that can look almost identical to a traumatic bowel injury on a CT scan, but its cause is completely different.
So what is shock bowel? It happens when the body is in a state of severe hypotension, dangerously low blood pressure. This could be from massive blood loss, septic shock, cardiac arrest, you name it. The body goes into survival mode and shunts blood to the most important organs, the brain and the heart, and away from the intestines. The bowel basically starts starving for oxygen, and it shows signs of distress that look a whole lot like our indirect signs of trauma.
So how in the world do we tell them apart? Well, we have to look for other signs of systemic shock throughout the body. With shock bowel, you'll see this whole constellation of findings. Yeah, the bowel loops are thickened and they're enhancing like crazy, but you'll also see a flat, collapsed inferior vena cava, or IVC. The liver and spleen might look kind of dull or hypo-enhancing, while the adrenal glands look weirdly bright. We call them bright adrenals. The kidneys are in distress too. All these clues tell you the problem is systemic, not just one localized injury.
All right, here we go. This is the final round. It's time to put these two conditions head to head. We're going to break down the absolute key differences so that you can confidently tell a focused traumatic injury from the great mimic, shock bowel.
This table really boils it all down. Let's start with wall thickening. In a traumatic injury, it's typically focal. It's just in one spot. But in shock, it's diffuse, affecting long stretches of the bowel. What about free air or leaked contrast? Well, you might see it in an injury, but you will never see it in pure shock bowel. And finally, look at the company it keeps. Injury might have a mesenteric hematoma nearby, while shock brings along its systemic friends, the flat IVC and those bright adrenals.
So listen, if you only remember one single thing from all of this, let it be this right here. The single most important difference is the distribution. A traumatic injury is a localized focal event. Shock bowel is a systemic, diffuse process. You have to look at the whole picture, not just the bowel, and that's when the diagnosis becomes clear.
And that pretty much wraps it up. Telling the difference between a bowel injury and shock is just one classic example of a great mimic in medicine, a condition that pretends to be something else entirely. It's a great reminder to always think bigger, consider the whole patient, and always ask yourself, what else could this possibly be? Thanks for joining us.